topic for today's discussion is hypertensive disorders of pregnancy. Hypertensive disorder of pregnancy, which is, a pregnancy-associated disorder, basically. So the severity ranges from mild to severe. There is less distinction about mild to moderate, no? So practically now we have only two classes. One is a mild or severe. There's an overlap between mild and moderate. So we do not, or the outcomes are almost same. So we club this, we take it as a mild, and the second comes to be severe. All right. Despite all these research in this particular entity of hypertensive disorder, we're still not very clear about the definition because it keeps on changing after a few years, and even the classification changes. And we are still not very sure at what blood pressure level we have to initiate antihypertensive therapy. So why is this important? First of all, why are we discussing this topic? Because the incidence is 8 to 10% and it causes maternal mortality increase. And the incidence is around 30% in India. Fetal morbidity and mortality increases, hospital admission rate increases, and even the labor inductions increase. Now, coming again to the basics. So what is the normal physiology? During pregnancy, cardiovascular system undergoes significant adaptive changes in order to ensure uteroplacental blood flow. Okay, this is what is required in pregnancy. The cardiovascular system undergoes certain changes so that more blood should go to the baby and more nutrients and more oxygen should go to the baby. All right. As far as uteroplacental circulation is concerned, there happens is what there is a trophoblastic invasion into the walls of the spiral arterioles, which transforms uteroplacental arterial bed into low resistance, low pressure, high flow system. This means the resistance of blood vessels in uteroplacental circulation is decreased peripheral vascular resistance. This causes more blood flow to the baby. All right. And so the one is a decreased peripheral resistance. Automatically, this means the pressure also is decreased, right? Once we have more dilatation, so pressure is decreased. So that causes an increase in blood flow. All right. So this is a normal mechanism which is required in pregnancy. That's how the nature works. If we fail in some circumstances, if we fail to have these changes, that leads to a development of hypertensive disorder of pregnancy. Again, try to understand. And this occurs in two waves. Wave one, where trophoblastic invasion of, this is the myometer level, it occurs only up to here. This is trophoblastic invade into the blood vessel only up to this. In the second phase, that means 12 to 16 weeks, it involves the spiral arteries also, which are there in the myometrium. Okay, this is what is happening in a normal pregnancy. If now, in any case, if this particular thing or the second wave does not occur, then what is going to happen is your trophoblastic invasion will only be up to this. And these vessels, which are spiral arteries, they will be still amenable to effect of hormones which cause them to be constricted, all right, or don't dilate. So two stages again in the process of pathophysiology, like how does preeclampsia develop? In first phase means second wave does not develop. So this means this is not there. It is only up to here, all right. And this is so first stage. So second stage, what happens is because of this, there is a maternal response, which involves a endothelial dysfunction. How now maternal response occurs endothelial dysfunction, and there is an imbalance between angiogenic and anti-angiogenic factors, resulting in the clinical features of the disease. All right. Now we understand two phases. One phase was that up to 12 weeks, there was a invasion by trophoblastics up to the myometrium. In wave 2, it was up to the spiral arterioles inside the myometrium. That was a normal. And if second phase or second wave does not occur, that leads to spiral arterioles amenable to effect of hormones which cause them to be constricted or do not dilate, so less is blood flow. So once there is less blood flow to the placenta or to the baby, there is a ischemia, there is ischemia of placenta, and that leads on to the endothelial dysfunction. So it is ischemia, right? Less blood flow leads to a decrease in, leads to ischemia, and that leads to endothelial dysfunction, besides many other things which we come to later on. So this is a primary factor. Because of decreased blood flow, there occurs ischemia and there is endothelial dysfunction. Altered trophoblastic invasion, small caliber responsive spiral arteries, placental hyperperfusion. I'll just change the ink color. There is a placental hyperperfusion and hypoxia, release of anti-angiogenic factors. This is what I call as, soluble tyrosine-like factor. And that causes what I told was, this is an anti-angiogenic factor, right? So this causes inhibition of growth of blood vessels. And that leads to a systemic endothelial dysfunction, and that causes hypertension. So we have placental ischemia that leads on to increase in matrix metalloproteinases, increase angiotensin 2, increase tumor necrosis factor, increase SFLT1, and increase in soluble endo. These two are proteins which you will always hear from probably your examiner also. Like, how will you predict what are the markers, biomarkers to predict preeclampsia? All right. So these are two important things which they most of the times ask you. So this leads to a increase in vascular endothelin 1, and that leads to a endothelin type A receptor and all those things, and ultimately leads to hypertension. And this also leads to proteinuria. If we further want to go into particular these things are produced by podocytes. All right. Podocytes are there in the kidneys. All right. And this is one of the reasons, and that leads to proteinuria. So if somebody asks you, what is the reason of proteinuria in PIH? Initially, what we were always telling was there is endothelial dysfunction or endotheliosis. It was thought to be endotheliosis, which was a reason for proteinuria in PIH or PET, whatever we call. But now it has been seen that there are certain cells with what we call them as podocytes. There is some problem with the podocytes, and that they lead on to a proteinuria in HDP. All right. Please remember this. And second thing which is happening is there are some genetic factors, there are some environmental factors, and why are these things happening? Why this abnormal trophoblastic invasion occurs in only few of patients? Why it doesn't occur in all? That means what is the etiology behind it? Who are the patients who are more prone to these types of HDP? So this is what they do is they impaired trophoblastic invasion, circulating, and these things increase. So they all cause hepatic microcirculatory deterioration. So liver dysfunction is there, glomerular endotheliosis, which I was talking about, that leads to proteinuria. In fact, this was a older thought. And now, addition to this, we have a podocyte trouble. All right, you can remember this. And then we have a periventricular edema in the brain. So we have problems in the brain. And then we have vessels, there's a increase of all all things which cause vasoconstriction. So there is a hypertension. So we have four things. We have effect on the kidney, we have effect on the liver, we have effect on the brain, and we have effect on the vessels, which causes hypertension. All right. Same here. So now coming on to the markers, no, the importance. This is what a question you always get in your exam. So if there is ischemia, it leads on to metalloproteins, matrix metalloproteins, they are increased. SFLT is increased. This we have, the inactive endothelin 1, they lead on to activation, and serum endothelin 1 is increased. There is a present insufficiency preeclampsia. Von Willebrand factor is also increased. Endothelial cell dysfunction, they lead on to serum VCAM1 increase, serum E-selectin increase, thrombomodulin increase, and all these things. So most important is this, which we most of the times we are able to measure in pregnancy, is SFLT1 and endoglins, right? Endoglins. So another thing is a sensory trophoblast derived extracellular vesicles. This is a latest story. They are, they come in the placental dysfunction, leads to release of SBVs in the blood, and they cause one, endothelial dysfunction. Second, they cause systemic inflammation, and third, they cause as coagulation disorder. And all these three things are, present clinically as preeclampsia. Okay. So coming on to how does this occur and why does it does not occur in all patients? This we all know that fetus is an allograft with half its immunological component which comes from the mother and the other half comes from the father. So the maternal component is her own, like mother's. So mother tolerates it, but component which comes from the father is immunologically distinct, and mother will always try to reject it. The conceptus therefore needs a perpetual protection from the rejection system of the mother. All right. So this means there is something which is, mother coming from the mother and coming from the father. All right. Some genes. Mother tries to, what it does is it has its own, or no, we call this innate. It has own. It recognizes its own, material, whereas whichever comes from the father, mother tries to reject it, right? Now, how does conceptus, otherwise every time you conceive and it will lead on to, pregnancy loss. So what it does is there is a perpetual protection from rejection system, from the rejection system of the mother. This protection is provided by the paternal immunological component, which we otherwise think is, it protects its own. So what it does is, these syncytial trophoblasts, they play an important role in protection of the conceptus. All right. So this is one part. So any pregnancy where there is immune tolerance is suboptimal, a series of effects takes place. Okay. What happens is if there is a defective trophoblastic invasion, we call this as obstetric vasculopathies. This is another question which comes in the exam is, what are the obstetric vasculopathies and what are the conditions associated with it, and how will you manage it? So if you try to go a step ahead according to that question, so this means PIH or hypertensive disorder of pregnancy, pregnancy losses, stillbirths, they all are obstetric vasculopathies are all reasons for this. So anything, anywhere where there's a disturbance in immune tolerance or it is suboptimal, it leads on to obstetric vasculopathies. One. Secondly, there is an excessive maternal response. What happens is there is a defective trophoblastic invasion, right? The second thing which happens is there is an excessive inflammatory response. Now, how does it do? It is directed against foreign fetal antigen, results in a chain of events. This means there occurs shallow trophoblastic invasion, defective spiral artery remodeling, placental infarction, and release of pro-inflammatory cytokines, which we have, understood in this thing, right? So these are systemic inflammation occurs, coagulation factors are right. Another important thing is what we call as crosstalk. So what happens in during a pregnancy, in normal pregnancy, is that trophoblastis blasts interact in the decidua with the unique uterine natural killer cells. And this 1:1 talk that modifies their cytokine, talking to each other and regulating adhesion molecules and matrix metalloproteins. Once this does not occur, there's a problem with the crosstalk that these two cells, trophoblasts and natural killer cells, do not talk to each other in a, this is how it happens in our human behavior also. If we don't talk to each other, there will be a trouble, right? So communication is very important. If there is no communication, like in this situation, that leads on to the onset of preeclampsia. All right. Complete failure of this mechanism can cause miscarriage. Partial failure can cause poor placentation, dysfunctional uteroplacental perfusion, and result in manifestations like preeclampsia, IUGR, and accidental hemorrhage. They are all part of the obstetric vasculopathies. Okay. Another thing is there is a genetic conflict theory. What happens is, like I told you, the mother tries to tries to reject paternal or father's genes. Similarly, it happens here also. Fetal genes are selected to increase the transfer. Fetal means here it is paternal. Anything which comes from the paternal, they basically are selected to increase the transfer of nutrients to the fetus. All right. Whereas maternal genes try to restrict this transfer. They are acting opposite because mother does not want, or maternal genes do not want, that beyond a optimal level, the food should go to the baby. All right. So she takes care of it. But similarly, fetal genes try to increase blood pressure. So one thing is fetal genes or paternal genes, they try to increase transfer. Secondly, they tries to increase blood pressure, and maternal genes tries to reduce blood pressure. All right. So this is a conflict occurring between the paternal and the maternal genes. Endothelial dysfunction may be a rescue strategy. Suppose mother is trying to reduce. No, what will fetus do? There will be an endothelial dysfunction. This means once endothelial dysfunction occurs, it tries to increase non-placental resistance. So once non-placental resistance is increased, say when there is an inadequate placental supply, so non-placental resistance increases. So this is a rescue mechanism by the fetus. All right. Now, another thing which has come very lately is a role of gut microbiomes in the development of hypertensive disorders. Now, it has been implicated that the bacteria in the gut, what we call as gut dysbiosis, is important and probably a factor for development of eclampsia or, sorry, HDP. Or how does it happen is maybe there is a breach of intestine and bacteria go to placenta, and these bacteria go to placenta, and there it causes a trouble in the placenta. All right. So this is another hypothesis that probably a role of gut microbiome. It is coming up in all diseases otherwise also. So they are now trying to implicate or tell that this is one of the factors which is possibly responsible for development of PIH. Now coming on to how does it happen? What we have understood is how does it happen, and why it happens means the reasons, genetics behind it. Now let's see what happens in the organs. Is a disorder of endothelial function with vasospasm. This is a standard which happens in all vessels, right? So histopathology of placenta will show a diffuse placental thrombosis, inflammatory placental residual vasculopathy, abnormal trophoblastic invasion of end arteries. And there will be altered maternal immune response to fetal and placental tissues, right? There is a genetic predispositions. Many genes have been implicated, but no one particular gene has been pinpointed that this is going to cause preeclampsia. Maybe with passage of time, we can pinpoint one particular gene, which we think will be able to justify or describe or mechanism. So there is increased vascular sensitivity to angiotensin 2, which we have understood. So imbalance between prostacyclins and thromboxane A2. In preeclampsia, this is more in this favor. There's increased oxygen-free radicals. This means there is decreased nitric oxide. All right. There's abnormal calcium metabolism. It has also been implicated. Vitamin E, C, antioxidant, and micronutrient deficiency, and inhibition of nitric oxide synthesis. I said I know is decreased. So this means it increases mean arterial pressure. All right. Now, it affects many organs because of vasospasm. So these are the changes which occur in mother. There is vasospasm. So vasospasm means resistance is increased. There is arterial hypertension. Then the release of angiotensin 2, right? And then there are vascular changes, local hypoxia, hemorrhage, and necrosis of tissue, and organ disturbances in mother. Fetus, there is a reduced uteroplacental perfusion, which may lead to fetal compromise, growth retardation, and oligohydramnios, and at times maybe a IUD also. In placenta, we see placental infarcts, calcifications, and there may be a abruptio placenta. Cardiovascular system. Cardiovascular system undergoes changes. There is increased cardiac afterload, which leads to hypertension, endothelial injury. In fact, these are the reasons for afterload, hypertension, endothelial injury. There occurs exacerbation that may be a reason in marked reduction in cardiac output, increased peripheral resistance. Blood volume, there is hemoconcentration, increased vascular permeability, and patient is sensitive to vigorous fluid therapy, even sensitive to blood loss at delivery. So we have to be very careful. Many times what we do is we try to increase, say give fluids or whatever. So that may be a trouble. So there's a minimum of, fluid which has to be say 60 to 70 or 60 to 80 ml, which we can infuse. We'll come to that slightly later again. So what are the changes which happen in a hematological system? There is thrombocytopenia. That means platelets are less than 1 million, right? 1 lakh, sorry. Then there is HELP syndrome. Again, there is hemolysis, elevated liver enzymes, and low platelet count. And the other troublesome disease occurs when there's a consumptive coagulopathy like placental abruption or profound hemorrhage, and then hemoconcentration occurs, right? What happens in kidneys is there's a decreased GFR because of decreased renal perfusion. There's increase in plasma uric acid concentration. Earlier, we used to take plasma uric acid concentration also as one of the prognostic factors, but now it is not taken as very important. Increased plasma creatinine levels more than 0.5 milligram per dl. Proteinuria more than 300 milligram per dl per 24 hours of urine, or +1 on dipstick test. Renal failure, tubular necrosis occurs. I said what happens in kidney is endotheliosis. All right. And that leads to tubular necrosis at times and oliguria and anuria. Liver, alteration is hepatic function test. If it is more than 2 times the normal values, this is what happens in your SGOT and SGPT increase 2 times, right? And in severe circumstances, there can occur a periportal hemorrhagic necrosis. There can occur hepatic rupture. There can be subcapsular hemorrhage. And last of all, there can occur is HELP syndrome. We'll come to all these things one by one again. If we understand again by organ system, what happens is cerebrovascular changes also occurs. Visual changes occurs. There is photopsia. That means we have floating lights or sparks which appear in front of the eyes. Dark spots are in the vision, what we call as scotomata. Amauroxy is there, blindness in one or both eyes. Like it feels like some curtain is coming down on your eyes. And then there can be a retinal detachment if the disease is severe. Headaches can occur. There's increased intracerebral pressure. There is over it over. So this is another line which or word which is important is auto-regulation. Up to one, suppose there is a decrease in blood, say decrease in blood supply. So there is what your brain does is it causes vasodilatation. All right. So this means vasodilatation. This means sorry, I'm so sorry. So last of all, there is a HELP syndrome, which is characterized by hemolysis, elevated liver enzymes, and low platelet count. Okay. It occurs in 20% of women with severe PIH, and it is associated with placental abruption, renal failure, subcapsular hematoma. And in this particular syndrome, there's increase in fetal as well as maternal mortality. So this is the difficult story. In brain, there can be edema, there can be hyperemia, thrombosis, hemorrhage, confusion and coma, visual disturbances, convulsions, eye, retinal hemorrhage, papilledema, retinal detachment, retinal ischemia, infarction. So practically, it is something like hypertension, which is at the end of the day damaging all organs. So there can be cortical blindness. Prognosis is usually good. Changes usually return to normal within a week if we control everything. This is a specific type of retinopathy which occurs, what we call as Butcher's retinopathy, due to choroidal ischemia in PIH. This is how it looks like.